person loss of contact with reality, and the person is unable to, there is a change in his perceptual ability, and he is unable to respond to the environment. And uh, now, just a second now. Yeah. So schizophrenia, it affects people from all walks of life, and it is about as prevalent as epilepsy, and it usually begins in late adolescence or early adulthood. So schizophrenia is, the prevalence is about 1%, and equal rates across men and women. And there is little variability in terms of prevalence cross-culturally. It doesn't differentiate. But it has been found that it is, there is frequently found more in among low socioeconomic status group. And people with schizophrenia are at greater risk for suicide and can also be victims of crime. So DSM-5 calls for a diagnosis of schizophrenia only after. So when you're going to, when we talk about diagnosis of schizophrenia, according to DSM-4, the criteria, you can only diagnose a person as having schizophrenia only after the symptoms of psychosis continue for 6 months or more. So 6 months is a very important criteria. An individual, along with the 6 months, individual uh, must also show a deterioration in their work. So basically, their functioning should also be affected in terms of their deterioration in terms of their work, social relations, and ability to care for themselves. So there are three types of symptoms, or you can say there are three kinds of symptoms of schizophrenia. Positive symptoms, we also call them as pathological excesses. For example, hallucinations, delusions. Then we have negative symptoms and psychomotor symptoms. So these are three kinds of symptoms which are found under schizophrenia: positive, negative symptoms, and psychomotor symptoms. So what do we mean when we talk about positive symptoms? Positive symptoms include hallucinations. Hallucination means false perceptions. So and most so it involved any perception. So basically, when we are talking about hallucinations, you're talking about your whatever information we get from our environment, from our surroundings. It is through our senses, our five senses. Okay, so there is the person. So hallucinations are can involve any of these five senses. That is, a person can have auditory, olfactory, tactile, visual hallucinations, and the person here, for example, under auditory hallucinations, the person will hear voices. Will talk about, like, somebody is talking to him, speaking to him. Will hear voices, sounds which are not there in the it's there is no evidence, or it is not there in the reality. Okay. And second, under positive symptoms, we also have delusions. Delusions means faulty interpretations or beliefs. There are different kinds of delusions, and there is different kind of delusions, and some of the examples are persecutory delusion, referential delusions, and we also have somatic delusions, religious delusions, grandiose delusions. So there are different types of uh, delusions experienced by a person under positive symptoms, like uh, so any idea? I some time back I had explained to you regarding ideas of reference. Remember? What do we mean by ideas of reference?
Ideas of reference, if I remember correctly, it's a recording of the memory
Huh?
which to be compared with the present sensation.
Huh? I'm unable to hear you clearly. Yeah.
It's a comparison of present perception with the recording of the past memory.
No, 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 no. I'm talking about delusions. So, ideas of reference or delusion of reference means a person will be having a false belief that insignificant, very normal, very neutral remark or a sentence by other people, and they will find some meaning in that. Okay, some insignificant, very neutral event or object in their environment, they will start to see personal meaning or significance in that. Okay, and they will see that those, if two people are talking, and if they are remarking or talking about anything, they will start to feel that they are talking about themselves. Okay, so that is what we call as delusion of reference. And then persecutory delusion. Persecutory delusions means false belief that one is being persecuted, people are after him, people are against him. Somatic delusion would mean delusion that it pertains to body functioning and body sensations. And usually, the false belief is that body is somehow diseased, abnormal, or it has been changed. They believe that they start to believe that so they are infested with insect, or something has been inserted in their under their skin. So that is what we call delusion of jealousy. Would be false belief that a spouse or a significant other is having an affair with no proof, no factual proof, no claim, nothing, no backing at all, but still they will, believe that they are being disloyal to them. Grandiose delusion would be, they'll feel that they have some superpower, they are very powerful, they have this godly abilities, you know delusions of grandeur, grandiosity. Okay, so these are some of the examples of delusions. And another type of so under positive symptoms, we have hallucinations, which involve which are basically false perception, and they involve your five senses. So they can be auditory hallucinations, they can be visual hallucinations, they can be tactile hallucinations, or olfactory hallucinations. So there is no smell in the environment, but they will start to, they'll continuously, they firmly believe that there is some smell, they are experiencing some smell. So that is olfactory delusion. I mean hallucination. Visual hallucination would be like they see something in the environment, they are able to, they see people, they see some shadow or something like that, which is not seen by anybody else around them. That is a visual, that comes under visual hallucination. The most common hallucinations found under schizophrenia are auditory hallucinations. And then delusion, which I just explained, that is faulty interpretations or belief. And the third under positive symptoms is disorganized thinking and speech. Disorganized thinking and speech, for example, like the person, the way they will talk will be very disorganized, and we have certain terms which we apply depending upon what type of speech they will have. For example, loosening of associations would be seen under disorganized speech. We call them as derailment also. For example, like there will be no association when they are speaking in their whatever they are speaking, there will be no connection between one sentence to another. For example, Ram serves drink at a coffee shop. I love candy bars. I went to maybe supermarket. So there is no connection at all in what they are talking. Okay, and then some of the another example would be they'll make up new words which are not there in any language dictionary at all. Okay, so we call them as neologisms. They make up words, for example, butterflower, something like that. Perseveration is also seen in their speech. Perseveration means the patients will repeat their words and statements again and again and again and again. For example, let's go to supper at the supper club with the supper. So they will repeat words or sentences again and again, and we call that as perseveration. Sometimes they will rhyme, you know, we call them as clanging. So, for example, how are you? Well, hell, it's well to tell, something like that. Okay, this speech will be very disorganized, and other positive symptoms might include some of the patients with symptoms of schizophrenia, especially positive symptoms. They will experience heightened perceptions. So people may feel that their senses are being flooded by sights and sounds. So patients will come with to you with complaints like, they will experience lights very sharply. Sounds are experienced at a very, they'll become very highly sensitive to lights and sounds, and which makes it very impossible for them to concentrate or attend to anything important around them, because they become highly sensitive to sounds and lights. And inappropriate affect is also seen. Affect means emotions. So uh, see, our whatever emotions we feel, they should be appropriate to the situation. So inappropriate affect is also seen under positive symptoms. That is, emotions that are not suited to the current situation. They, not suited to the situation, completely different to the situation. And then negative symptoms. Under negative symptoms, uh, uh, poverty of speech, and the technical term for poverty of speech is elogia. That is, there is a very, almost negligible amount of speech. The person would not communicate, would not interact, is observed. Flat, flat or blunted affect. That is, no emotions at all, very blunt face. Okay. Uh, and there will be very poor eye contact. Even when they are talking also, they'll talk in a very monotonous voice, no expression on the face, no emotion in the voice also. Face will appear as if it lacks any emotion. So we call that as flat effect or blunted effect. Loss of volition or avolition or apathy, that means there will be a lack of initiation in any activity. No initiate, they'll be just sitting. No, or if they are given any work, they will not take any initiative. They will not follow through with anything, and there will be extreme social withdrawal seen under negative symptoms. So, see, completely opposite. Positive symptom, there is an excess of everything. Negative symptoms, completely opposite to positive symptoms. Okay. So that is why we, when we call about, when we talk about positive symptoms, we use the term pathological excesses is seen under positive symptoms. Okay. Then the third symptom is under schizophrenia is psychomotor symptoms. So under psychomotor symptoms, we observe there, some of the examples would be, there will be catatonic stupor. Catatonic stupor means patients will stop responding to environment. They will be motionless, mute. Catatonic rigidity will also be observed in some of the patients. Catatonic rigidity would be very rigid posture, resisting any movement. Catatonic posture, that is very awkward type of positions. They'll sit in a very bizarre, very awkward position. Catatonic excitement, that is wild waving of arms and legs is seen under psychomotor symptoms. Okay. So three symptoms under schizophrenia. Then now, I don't know whether they have talked about this in your lesson or not, but there are different subtypes. According to DSM-5, we have different subtypes of schizophrenia. But before that, we also, like, depending upon the course of schizophrenia, we also differentiate schizophrenia into type 1 and type 2 schizophrenia. So type 1 schizophrenia is dominated by positive symptoms. That is, hallucinations, delusions, disorganized speech and behavior. Uh, uh, and type 2 schizophrenia is dominated by negative symptoms. Okay. So if a patient comes to us with type 1, that is positive symptoms, we will be very happy, because uh, person will be there will be, in his or her prior history, you would find better adjusting personality, and likelihood that there will be greater likelihood of improvement, and prognosis will be good if a patient comes with type 1 schizophrenia, that is positive symptoms, and there will be later onset of symptoms, and it is more closely tied to biochemical abnormalities. So medicines will be able to work very well in this. Type 2 schizophrenia, we will be, it's tied to structural abnormalities. So you see, there are no medicines to correct structure. You can, we have medicines to correct the chemistry, the biochemical chemistry of our brain, but we cannot, if there is some sort of a structural abnormality, you cannot reverse that. Okay, and negative symptoms, we will not be so positive regarding the prognosis. Okay, so now coming to uh, what causes schizophrenia. What are the causal factors behind schizophrenia? So genetic factors are clearly implicated in schizophrenia, and the closer you are to the person who has schizophrenia, the risk increases significantly. So, for example, first degree relatives, that is, almost 50% gene sharing, your chances will increase almost up to 46 to 48%. And second degree relatives would be like, grandchildren, nephews, nieces, uncle, aunts. So chances are, around somewhere around 5 to 4%. Third degree relatives would be first cousins, like that. So 1 to 2% of chances. So the closer you are genetically to the person who has schizophrenia, the more chances of inheriting schizophrenia. So monozygotic twins are much more likely to develop than dizygotic twins, because monozygotic twins, uh, almost a copy. They why mono what do you mean? Like, do you know what is monozygotic and dizygotic?
Madam, monozygotic is one zygote from which
Mm,
the fetus
correct.
develops.
Yes.
Di means two. Two
Yes.
zygotes, they will have twins, but different sex are something different. Two
Yes, so it's
zygotes.
completely, there is a splitting of genes, isn't it? It's a
Yes.
mirroring of genes. So that is a risk is much more in monozygotic compared to dizygotic. Okay, and other biological factors that have been implicated in the development of schizophrenia includes prenatal exposure to influenza virus. Lot of research has supported this, that early, even as early as prenatal exposure, that is, if the mother has been exposed to some viral infections, especially influenza virus, then chances, the risk for the fetus, the offspring to develop risk increases in the offspring. And early nutritional deficiencies have also been linked with schizophrenia, and also prenatal birth complications can have also been implicated or found to increase the risk for developing schizophrenia later on. And current thinking, what we believe in the current thinking is that, there is an interplay between genetic and environmental factors. Okay, so the person, see, for example, like, a person might inherit uh, a vulnerability, or towards genetic vulnerability regarding schizophrenia. People might have a biological risk for schizophrenia. Okay, and then might only develop symptoms if they experience certain. So for example, like, how I can explain this is, see, we know that, there are certain physical illnesses which we might inherit if there is a family history, for example, diabetes, hypertension, to name a few. But it is not a guarantee. Just because there is a family history or your parents have diabetes doesn't mean that your vulnerability, your risk is more compared to the general population, because you're carrying that vulnerability. But if you live, maybe if you have a good healthy lead a good healthy lifestyle, so it might be that you might not develop diabetes. But if you have, there is a vulnerability, and along with that, if you lead a very unhealthy type of lifestyle, lot of stress, lifestyle includes a lot of air stress, then it will trigger that vulnerability, and it will increase the chances to develop diabetes. So similar logic applies here also. So, and we call this as diastasis stress relationship. So people, individuals might have a biological risk of schizophrenia. That is, there might be a family history. That is diastasis. That is vulnerability, but might only develop. So just because you carry a vulnerability, just because you have a family history, doesn't mean that you are guaranteed to have it. So later on, there is a interlinked relationship between, later on, this can get triggered. A person might develop symptoms if they experience certain kinds of stress later in their life. Okay. So now, under biological factors, we also have, we consider schizophrenia as a neurodevelopmental disorder also. So what we believe is that, some of the researchers, they say that, during childhood or during infancy, there might have been a lesion in the brain. Lesion means some sort of a injury, or is, medically, lesion means some sort of injury. Okay. So lesion, there might have been some a region in the brain or a tissue which might have suffered some damage because of disease or injury. It could be a wound, ulcer, abscess. So that is what we call as lesion. So a lesion in the brain is thought to lie dormant until normal developmental changes occurs. Okay, and these changes expose the problems and that result from this brain abnormality. So as the brain starts to develop, then the changes start to occur, and these changes will trigger problems in the brain. And they have found that many areas, during postmortem studies of patients who had schizophrenia, they have found that many brain areas are abnormal in patients with schizophrenia, such as they found that patients who had schizophrenia, their brain showed decreased volume. They had decreased brain volume, enlarged ventricles, and frontal lobe dysfunction was observed, and there was reduced volume of the thalamus, and they also found abnormalities in temporal lobe areas such as hippocampus and amygdala. And now biochemical causes would be, they have found that two neurotransmitters, uh, uh, dopamine and glutamate, these two neurotransmitters have been implicated in schizophrenia. And people have found that, imbalance in these two transmitters, dopamine and glutamate, can trigger symptoms of schizophrenia. Now, psychosocial and psychological and socio-cultural causes. So many theories, early theories, they used to believe, like in 1900s or something like that. So they used to believe that, they had theories about bad families causing schizophrenia, but these theories have not stood the test of time. That is, there is no research backing, but we need to speak about this. So early theories, they talked about schizophrenic mother. That is like, according to them, children whose, the mother, who, uh, you know, uh, they found that, like, in the term which they use is refrigerator mother, like mother who's very cold towards their child, uh, emotionally distant, would not fulfill the emotional needs of a child. they theorize that children of such a parent would later on develop schizophrenia. But this did not now this theory is just proposed. I mean, it's not like substantiated by research, and it has not stood the test of time. Okay. And another theory called double bind hypothesis, where, like, if the child is given dual communication, for example, like, parent is saying something, and their expression is completely opposite to what the parent is talking about, like, for example, they give permission, yes, you can go out to play. Okay, so their permission is given that, yeah, you can go out to play with your friends, but their facial expression is completely opposite, that, they are not happy. So now child, this confuses a child, like, what should he listen to, whether he should listen to the words of the parent or the expression, facial expression. So this confusion can later on trigger they find that this double bind hypothesis is responsible. These two theories were early theories, and they don't really they have not stood the test of time. Okay, they don't apply to current times. So instead, researchers currently find that the communication problems could be because of the result of having a person with schizophrenia in in the family. Okay, so it could be like, these communication problems not because of the mother or parent or the alpine hypothesis. It could be because one of the family members or the parents themselves might have schizophrenia, and because of which, the children might be vulnerable. And patients with schizophrenia are more likely to relapse if their families are high in expressed emotion. Expressed emotions are, this is a term uh, which, you will be hearing about a lot. Expressed emotion means emotions expressed by the family members towards the patient. And expressed emotions can be like, sometimes, especially in Eastern countries, parents or family members, we believe that, if you want a child to progress, or criticism, over involvement. Okay, so certain cultures, like especially Eastern cultures, they believe that, if you praise a child, uh, you are spoiling them. Okay, so, or sometimes, excessive, or, these excuse me, overprotection. Okay, so, so expressed emotions are have been found linked with relapse. That is like, see, the person after treatment, getting treatment, comes back to the home, okay, and finds that, uh, he or she wants to move forward, but then the family members will not allow them to, forget about it. So continuous criticism uh, on the part of family members, over involvement, has been found to be linked with relapse. And a large evidence, like a lot of research has indicated that the lower their socioeconomic status, the higher the prevalence of schizophrenia. And two theories have been presented to explain this. One theory is sociogenic hypothesis, and another is social drift hypothesis. So why is it that, large number of cases are found in low socioeconomic status compared to other groups? Is because, like, one theory says, uh, by virtue of belonging to that group, like, so low socioeconomic status group itself is stressful. So there will be, like, the person is will be under extreme poverty, lack of resources, lack of opportunities, a lack of health care. So by, just by belonging to that economic status can trigger, that is what we call a sociogenic hypothesis, can trigger schizophrenia or mental illness. Social drift hypothesis, the other theory says that, people who might have belonged to upper middle class, or the rich class. So what happens is that once the symptoms of schizophrenia start to show, or mental illness, so what it affects a person's functioning. So the person might not be able to function well in his profession, might not be able to function well in his job or whatever it is. And because of that, his social, I mean, what I can say, financial status might come down and put him in that low socioeconomic group. Okay, and it appears that a lot of research has found that both these theories to be true. So now, what are the treatment options for schizophrenia? Yeah, before coming to that, I want to, I told you there are subtypes of schizophrenia, isn't it? So there are different subtypes of schizophrenia. Paranoid schizophrenia. Under subtypes of schizophrenia, we have paranoid schizophrenia, disorganized schizophrenia, catatonic schizophrenia, undifferentiated schizophrenia, and residual schizophrenia. So, what is paranoid schizophrenia? Here, the person will be preoccupied with one or more delusions and hallucinations. So hallucinations could be auditory or could be visual, or any of the hallucinations. And delusions usually would be like, persecutory, that people are after me, they want to hurt me, they want to do something to me. Okay, people are planning against me, they are conspiring against me. So or grandiose delusions, like, I have superpowers, I am God, I am this, I am this rich person. So such type of delusions are very common under paranoid schizophrenia. Okay, so hallucinations and delusions are found under paranoid schizophrenia, but they will not have disorganized, they will not show disorganized, the other positive symptoms, such as none of the following is prominent, that is, disorganized speech will not be prominent, disorganized behavior will not be there, catatonic behavior will not be there, or flat or inappropriate effect will not be seen under paranoid schizophrenia. So the main symptoms observed in paranoid schizophrenia is hallucinations and delusions without any disorganized speech or behavior. Under disorganized, now the second subtype is disorganized schizophrenia. So here, as the name itself suggests, person will be showing symptoms of disorganized speech, disorganized behavior, flat or inappropriate affect. There will be no catatonic behavior. And catatonic schizophrenia, it is again a type of schizophrenia in which the clinical picture is dominated by at least two or more catatonic behavior. That is, you can see catatonic inflexibility, that is motoric inflexibility, and excessive motor activity, extreme negativism or mutism, that is, they will not talk at all only. And or sometimes peculiarities of movement, like, bizarre posturing, stereotype movements, some mannerisms, grimacing on the face will be observed, or repetition of whatever is said or done. Whatever you say, they will repeat it. Okay, so this is what we call as catatonic schizophrenia. Undifferentiated schizophrenia is characterized by symptoms which do not fit paranoid, disorganized, or catatonic subtypes. It is basically catch-all category. So symptoms, if they are not fitting paranoid schizophrenia, disorganized, or catatonic type, they will put it they'll put it under undifferentiated schizophrenia. And residual schizophrenia is, here it is characterized by symptoms that have lessened in strength and number. So the symptoms would be milder. Okay, symptoms have lessened in their strength and number, and person may continue to display blunted or inappropriate emotions. That is, person might show inappropriate emotions which are not in line with the situation. So these are the different subtypes of schizophrenia. So we also have, like, different psychotic disorders. Uh, Other psychotic disorders are also there, like, apart from schizophrenia, we have schizophreniform disorder, brief psychotic disorder, schizoaffective disorder, delusional disorder. and shared psychotic disorder. I'll fastly talk about this. So, under schizophreniform disorder, uh, so here the symptoms of schizophrenia are met, but here the duration will be different. For example, for schizophrenia, we don't diagnose a person as having schizophrenia unless and until the symptoms are there present for at least 6 months or more. 6 months compulsorily or more. For here, an episode of the disorder should last at least 1 month but less than 6 months. So the symptoms are present minimum for a month but less than 6 months, then we put that person as under schizophreniform disorder. So essentially, it's exactly like schizophrenia, but duration is shorter. And sometimes it is often used as a provisional diagnosis during the first months of the psychotic illness or first months of schizophrenic illness. So, for example, if an individual goes with the symptoms of schizophrenia and the symptoms have, or parents or patients, family members take a patient or a person to the doctor, and the symptoms have been there for maybe at least for a month or 2 months, so he does not fulfill the category of criteria for schizophrenia. So so this schizophreniform disorder will be used as a provisional diagnosis. So thus, this diagnosis will change after 6 months have passed without any complete recovery. If there is a recovery, then the schizophreniform will be maintained. Otherwise, if the symptoms are persisting beyond 6 months, then the diagnosis will change to schizophrenia. Then we have brief psychotic disorder. Here, presence of one or more of the following should be there, and that is delusions. At least one of the following delusions either should be there: hallucinations, disorganized speech, or disorganized behavior. So one of them should be, at least one or more have to be present. Again, here again, like so the duration is important in these other psychotic disorders. Okay, so duration of an episode of disturbance is should at least be 1 day but less than 1 month. Okay, so with eventual return to pre-morbid levels of functioning. Pre-morbid means uh, uh, the person, the type of functioning the person had before the start of the illness. So disturbance should not be accounted by any mental disorder, either mental disorder, or should not be due to any medical condition. Okay. So any of the symptoms of schizophrenia, that is either delusions, hallucinations, disorganized speech, or behavior. But the duration of an episode can be should at least be 1 day, but less than 1 month. Brief psychotic disorder, difference between schizophrenia, brief psychotic and schizophreniform is basically the duration. The criteria is the duration. Now, schizoaffective disorder, here a person will have an uninterrupted period of illness during which at some time there will be some depressive episode or a manic episode or a mixed episode, that is both depression and mania, concurrent with symptoms of schizophrenia. So the person is having symptoms of schizophrenia, and during that uninterrupted period of illness, during that uninterrupted period of schizophrenia, the person will also either have a depressive episode or a manic episode. So during the same period of illness, there will be hallucinations or delusions for at least 2 weeks. Okay, I then you will call it as schizoaffective disorder. Symptoms that meet criteria for a mood disorder or mood episode are present for a should be present for a substantial period of total duration of illness. So they should be present. If no mood disorder or mood is episode or mood disorder episode is there, you cannot give a person a diagnosis of schizoaffective and should not be due to any medical condition. Delusion disorder is here the person will experience delusions for at least 1 month. So, and another is hallucinations are not present under. So, delusions are present, hallucinations are criteria for hallucination should not be met. However, tactile or olfactory hallucinations may be present if they are related to some sort of a delusion. But hallucinations should not be uh, the symptoms. Okay, and the functioning of a person is not impaired, and the person is able to carry out his everyday activities, and the behavior will not be seen. His behavior or her behavior will not be seen as odd or bizarre, and it should not be due to any medical condition or substance abuse. So with this, okay. Now the next is shared psychotic disorder. Shared psychotic disorder, here what happens? A person might develop a delusion in the context of a close relationship with another person who already has a delusion. Okay. So you might have heard cases where the whole family were sharing a delusion. Okay. And there will, the delusion is, there will be like, the whole family. You heard about cases? Whole family themselves are paranoid about certain things. Okay. So or a person who's already under delusion can influence another person, uh, and the other person will start to share that delusion. Okay, so delusion is similar in content to that, or the delusion should be similar in content to that of the person who already has an established delusion. And again, this should not be accounted by any medical condition. So the delusions, for example, delusion can be shared between two people who are in a close relationship, such as a husband and wife, parent and a child, siblings, or the whole family together. So, and typically the person with the original delusion, it will be the more dominant personality in the relationship. It could be like, the male figure in a family or the father, and he might be like paranoid, and then that paranoia will be shared by his wife or his children also. So generally the delusions are only shared by two people, but can be shared among large groups of people as well. So with this, we finish with the different subtypes of schizophrenia and also different types of psychotic disorders. Okay. So now what is the treatment for schizophrenia? So medical treatment, antipsychotic drugs work by blocking. So antipsychotic drugs are given to persons suffering from schizophrenia. And how do they work? They work by blocking dopamine receptors. And so there are two types of antipsychotics, conventional antipsychotics and novel antipsychotics. And patients taking novel antipsychotics, they have fewer side effects compared to conventional antipsychotics. And people tend to do better when taking novel antipsychotics. That is the third generation, the current type of medicines which have been developed. And when it comes to psychotherapy, we have see before, like, the development of these medications, uh, psychotherapy would not, like, really work, because the persons, the symptoms would be, what you can say, so prominent that, unless and until, like, the person will not listen to the therapist. Okay. So now what has happened is, because before the discovery of antipsychotics, psychotherapy was not an option for schizophrenia. Why? Because they were simply too far removed from reality to benefit from psychotherapy. They were, psychosis is loss of touch with reality. Okay. So they will not benefit from psychotherapy. But today, in the current times, psychotherapy can be very helpful when used in combination with medication. Okay. So once the medications or medicines, they start to take effect, once the symptoms they come down, then the work of a psychotherapist or a psychologist will start. Okay. And the most effective form of psychotherapy is includes insight therapy, family therapy, and social therapy. Okay, and family therapy is very, very important because as I told you, it will help in reducing high levels of expressed emotions, and family therapy will also help with better communications among family members and how to communicate with the patient. Okay, and other psychosocial approaches will include teaching social skills training to the patient, and cognitive behavior therapy has also been found to be effective. So with this, we finish schizophrenia. Okay. Now, as we don't have much time, I am going to start with cognitive disorders, and we still have 10 minutes. Okay. Because I am left with only 3 days, I think. 3 days, isn't it? And we have to finish a lot of lectures. So, any idea what are cognitive disorders? What do we mean when we talk about when I am saying cognitive disorders? Are you all there or went to sleep?
No, no, no.
So, cognitive disorders are a type of brain disorders affecting higher order brain functions such as cognition, perception, memory, reasoning, learning, creativity, our judgment, and decision making abilities. So these are disorders which affect our brain, functioning of our brain. Okay, and the most see under cognitive disorders we have delirium, dementia, and amnesia, and in your lessons they have covered delirium and dementia. Okay. Excuse me. So cognitive disorders are defined as dysfunctions or deteriorations of brain functioning. And how do they occur? Cognitive disorders may occur from temporary or permanent changes in the function of the brain as a result of. So here you have to understand very till now whenever I was talking about disorders, one of the important criteria is the symptom should not be because of any medical condition. The symptom should not be because of any medicine, or symptom should not be because of any disease or because of any drug use. But here, when I'm talking about cognitive disorders, these disorders could be because of a result of genetic predisposition or infections or toxins or some metabolic disorders, that is physical disorders, or because of some injury. Understand? So psychological causes will not be linked with cognitive disorders. Okay. So cognitive disorders, they occur as a result of genetic predisposition. That is, we carry a gene, we carry a vulnerability for cognitive disorders. Infections can also trigger cognitive disorders, some toxins in the environment, metabolic disorders, or injury. So, as I mentioned, there are different types of cognitive disorders: dementia, delirium, and amnesia. So, today we will talk about delirium. Okay. So, what is delirium? Delirium is a transient.
It's part of
Huh?
uh,
Lack of
sub,
focus,
Hmm?
sub,
state of
subconsciousness.
confusion, madam.
Correct. And
Lack of focus,
uh,
lack of focus,
yes, yes, correct. You're correct. Okay.
maybe some disturbances in memory.
Yeah. So it is a, when we talk about delirium, see, when we are talking about dementia, it is a chronic condition. Okay. But when we talk about delirium, it is a transient condition. And it could be because of fever or some substance abuse, and this can be corrected. Okay. So dementia, you cannot reverse. Understand? Delirium it is there for a short period of time, could be for hours or days. Okay. So delirium is a transient mental disorder characterized by impaired cognitive function and reduced ability to focus, sustain, or shift attention. Okay. So it is lasting, it transient, it lasts only for a short period of time. It is not permanent. When compared to dementia, dementia is permanent. Okay, you have to be, so cognitive disorders, you have to be like very clear in this. Delirium, dementia. Okay. And this disturbance can develop over a short period of time, uh, usually hours or days, and generally fluctuates during the course of the day. And this delirium is associated with disturbance in the sleep-wake cycle and an increase or decrease in psychomotor activity. So you might have like, observed small kids or even adults also. When we have high fever, like, very, very high fever. So they will start, you will observe the state of delirium during that condition. Okay. So while sleeping, they will be like, sometimes they'll become very agitated, or there will be a decrease in activity, or they'll start to experience, they'll start to see certain things in that state. Okay. So delirium usually lasts for a few days. Sometimes it can persist for weeks or even months also. So what are the signs and symptoms of delirium? So one is difficulty focusing, sustaining, or shifting attention. So problem with attention, and memory impairment, and especially impairment in recent memory. Disturbance of the sleep wake cycle. For example, like, they'll feel drowsy during the day and agitated or restless at the night. So sleep wake opposite. So usually we'll feel drowsy in the night and uh, you know and active during the day. It will be, there will be a disturbance in that cycle. And disturbance in speech or language is also observed. For example, there will be, when they are in a state of delirium, there will be like, problems with the speech. They'll ramble. There will be rambling. For example, rambling speech is observed. Disorientation to time or place and also is also observed. So they'll not, disorientation time place means they will not know what, you know for example, if I ask you now, what is the time? So you don't have to look at the watch also. You can make a guess, and it's night and it could be around 9 o'clock, like that. But they'll not be able to, they'll not be oriented to time. They'll not know it is day, night, afternoon, and also not oriented to place. They will know where they are right now. Okay. And disturbance in psychomotor behavior. For example, a very agitation, they'll experience agitation with increased motor activity, and behavior and sluggishness with decreased psychomotor. So opposite also. It could be increased activity, or there could be decreased psychomotor behavior also. Sluggishness can also be observed. Emotional disturbance such as mood swings that can change over a course of day, and misinterpretations, that is illusions or hallucinations such as seeing, hearing, or feeling things that are not there. Okay. So any experience, while have seen people, during high fever, like, especially small kids or adults, when high fever, they'll start to see things, hear, feel things. Okay. Illusions. So what are the causes of delirium? Delirium has a high number of, lot of causes. It could be result of, because of any medical condition, substance abuse, or withdrawal also. Withdrawal means like suddenly, if the person is in a habit or has an addiction towards some medication or drugs, and suddenly without tapering it off, they stop, then the body might start to show withdrawal symptoms. And one of the symptoms could be delirium also. And it could be because of multiple etiologies also. Two, three most conditions can trigger this. So, and in older patients also, delirium is observed. And also there is a small proportion of delirium cases in which the cause cannot be identified. So what are the conditions that are commonly associated with delirium? Uh, they are like, general illness and affect infections such as pneumonia or urinary tract infection, disorders of the central nervous system such as stroke or subdural hematoma, disorders of the heart or lungs such as heart or respiratory failure, medication use, disorders of metabolism such as kidney failure or dehydration can, that is why sunstroke, heat stroke uh, should not be taken lightly. So what is epidemiology? Around 10 to 15% of older people admitted to hospital are delirious at the time of admission, and further 5 to 40% are estimated to develop delirium while in hospital. So there are different types of delirium: hyperactive delirium, hypoactive delirium, and mixed delirium. What is hyperactive delirium? Here, the person would be physically, verbally aggressive, agitated, would wander here and there, physically hyperactive, very alert to stimuli, and mood swings would be observed. So, hyperactive delirium. Hyperactive delirium, completely opposite to that. Lethargic, withdrawn, decreased response to any type of stimuli. You'll try to make them, respond to you. They will not respond to any type of stimuli. Physically hyperactive, they'll be inattentive, very slow to respond, and there will be, their thinking will be very clouded, and they will be, you'll have to use aggressive stimuli to make them respond. Mixed would be an evidence of both hyperactive and hypoactive behavior will be observed under mixed type of delirium. So, what are the risk factors of developing, risk factors for delirium is if a person has pre-existing cognitive impairment, such as if a person has pre-existing conditions such as dementia, then the risk for delirium increases. Visual impairment is also a risk factor. If a person has, if a person is addicted to alcohol or dependent upon alcohol, then that can lead to delirium. Age is also a risk factor. So above 70 years, age around from 70 to more above is also a risk factor for triggering delirium. If there is a previous history of delirium, then risk also increases. And patients with comorbidities such as if patients have hypertension, they had a history of stroke, chronic obstructive pulmonary disease, then risk increases for delirium. Okay, so with this we are finished delirium. And what is the treatment for delirium? The doctors, the moment they identify the cause behind delirium and